Okay, guys, I have to warn you. My neighbors upstairs are drilling, so this could be, I don't know. I hope this recording works out okay. We'll see. They're not drilling a lot, so it might be okay. Tibial plateau fracture was not part of our initial curriculum for this class, but I discovered that you guys are seeing a lot of tibial plateau fractures, and there is some important things to keep in mind because you do have to be more conservative with this type of fracture population. So that's why we added this into the curriculum. So tibial plateau fractures, the tibial plateau, it's important to understand the anatomy with this with this type of fracture because so much soft tissue is affected if there's a tibial plateau fracture. So if you think about it, the anterior 1/3, and I'll show a picture in a second. Anterior 1/3 of the tibial plateau is where the patellar tendon attaches. And obviously patellar tendon, very, very important. We actually did a patellar tendon repair recording as part of module 3. Obviously that's what makes our quadricep work and our knee extension happen. So we need our patellar tendon. The lateral aspect of the tibial plateau is where the IT band attaches. So obviously that's important as well for stability. And then the ACL, PCL, and meniscus all attach to the tibial plateau. When we think about where the weight bearing occurs, it's primarily along the medial plateau. So 60% of our weight is on the medial aspect, which is why when we tend to have issues with osteoarthritis, we tend to have the wearing of the cartilage and sometimes more meniscal injuries to the medial aspect of the tibia and the femur, because this is where we get most of more of our weight bearing. So that's just something to think about again when we're starting to do rehab with this group. So again, looking at this picture, the picture shows that this is both kind of the posterior part is on top and the anterior part of the plateau is on the bottom. And so you'll see on the top, that's where we have the ACL attachment along the tibial plateau. And then you'll see the lateral meniscus to the left, medial meniscus to the right, and then anteriorly, that tibial tuberosity, that's where the patellar tendon is going to attach. And so if there's a fracture in this area, which we'll talk about why that happens, or when it happens, then any of those structures could be affected. PCL, MCL, LCL also attach. So any of the ligaments that we think of with the knee, as well as meniscus, as well as patellar tendon, any of those things could be injured during a fracture. That's why this one is so difficult, because it's not just a fracture of bone, but it's usually affecting soft tissue. So when does this happen? It could happen with a low energy trauma for older people. I rarely have seen that though. I think maybe just once in China where it's been from a low energy trauma, so like a fall or something. But usually it's happening with a high energy trauma. So most of the time, honestly, it's going to happen when you are hit by a car or you're a scooter and on your scooter you fall or hit a car. Those are the most common things that I've seen here in China. And so these are high energy traumas. There's usually some varus or valgus force, so some medial force or lateral force, and then loading directly through the knee, through the proximal tibia, or tibial plateau as we call it. So falls can also lead to tibial plateau fractures. Sports injuries can also cause it, but again, that's rare. That's only if you're in high contact sports like football, like American football or rugby or something like that. Otherwise, again, you guys are getting these accidents are happening in, I would say, the Chinese population from scooter accidents, car accidents, pedestrians getting hit by cars, those kinds of things. So x-rays are really, really helpful to just get a primary diagnosis, but then they're going to need to do a CT scan because they have to be able to figure out, again, it's not just bone. So once they see that maybe there's bone damage, then they need to be able to see how much soft tissue damage is occurring. So that's why we need an MRI or a CT scan. to diagnose if there's other issues going on. There are lots of different classification systems for how these fractures are classified. So I'm just going to talk about basically one of them and kind of show you a couple of pictures, and we'll just kind of focus on that. But basically what they're trying, as they classify them, they're looking at, okay, was the injury to the medial column, so medial aspect of the plateau? Was it more to the lateral part of the plateau or more to the posterior part of the tibial plateau? So you can see here we have this shot sticker, maybe? I don't know. We'll say that's right. Classification. And you'll see that type 1, which I'll show you in a minute, is minimally displaced. Minimally displaced wedge fracture. That's just on the lateral aspect of the plateau. This can happen usually in younger people because their bones aren't fully developed yet. And so they're more likely to have type 1. It's the lateral aspect, so it's not going to be as big of a problem. And we'll talk about that and why that is in just a little bit. Type 2 is also a lateral type of fracture on the lateral part, but this is where it actually becomes depressed, so it pushes down. This is usually going to happen with some sort of high energy injury. And it's usually going to include some ligament or meniscus damage. This group, where we're going to see this more frequently, is going to be in your osteoporotic patients, maybe, again, who had a fall or something like that. They're going to end up with that type 2. Type 3, also usually in older people, and we're going to have that low energy fracture, but there's no depression or displacement. There's just a little dip where there's a little bit of a break, what's the word I want? It collapses in the middle, and you'll see that in the picture. It kind of collapses along the plateau. So with this one, again, you could have soft tissue damage for sure. Type 4 is the medial plateau. Type 4 is medial plateau with soft tissue injury. And because there's a lot of soft tissue injury with this one, it's a problem because there's a lot of important soft tissue along the medial aspect of the tibial plateau. Type 5, also very bad because you're getting medial and lateral plateau injury. You're also getting some depression of the bone, so ACL, probably meniscus damage with this one as well. And then type 5 is the worst. It's like everything is open. Everything is fractured. So here's a picture. You can see type 5 and 6, everything, both sides are fractured. There's collapse in the in the tissue along the tibial plateau. So again, type 1 is not too bad. Type 2, there's a little bit of damage to soft tissue. Type 3, there's really just damage to soft tissue. And then 4, 5, and 6. When we talk about medial plateau fractures, we can get different kinds of subtypes. So how it's, again, there's so many different ways to classify this. I wouldn't worry too much about it. The main things you need to recognize are, was the medial aspect fractured, or was the lateral aspect fractured, or both? And then what soft tissue was damaged? Because if the medial aspect was fractured, then you're more likely to get issues with ligament injury like ACL, and they're more likely to have complications like osteoarthritis. So again, this area is messy. Fractures in this area is messy. So non-operative treatment is probably not going to happen very often. We'll talk about contraindications for surgery here in just a second. It's only going to happen in people that have very significantly decreased mobility. So if there's somebody who's going to not be moving very much in their future, then they may choose to do the non-operative treatment, but the vast majority are going to need an operation. If they're doing non-operative treatment, they're going to be casted. I'm not sure how long. They didn't really say in the literature how long. I think it's just dependent on the surgeon. And then once they're out of the cast, you're starting to do passive range of motion. Usually they can start doing weight bearing as tolerated at about 10 weeks. So again, this is a long immobilization, relatively long non-weight bearing period. And then once they can do weight bearing as tolerated, actually even before that, because you can do passive range of motion, you can do the non-weight bearing exercises and activities that we're going to talk about in our protocol. But then once their weight bearing is tolerated, then you're going to be able to move through those weight bearing activities as well. So with surgery, this is one of the few situations where it's better to wait. So they'll usually wait 7 to 10 days to allow for as much soft tissue healing as possible. If there's a lot of soft tissue damage, well, even if there isn't, there's going to be inflammation of the soft tissue around the tibial plateau. And so you're more likely to have complications with different problems with the soft tissue afterwards if they go in and do surgery too early. So they're really, really waiting on trying to get the soft tissue to heal, decrease that inflammation, those kinds of things before they do surgery. So the patient's going to be kind of laying around for a little while before that. So again, most patients will get surgery, 85%. The ones that don't are the older people, the ones that just don't have good functional mobility. They didn't have good functional mobility, or anybody who's cognitively not aware. So most of the patients that I've seen, I've never seen anybody who's had a non-operative tibial plateau fracture, because most of the people that this happens to are young people. So they need surgery. So the technique is dependent on the fracture type. I'm going to show you just lots of pictures of what this looks like. It's always going to be some sort of ORIF, internal fixation. And we really want to try to do the technique. The surgeon's going to try to do the technique so that we avoid injury to the soft tissue. So you'll see the way they put in that hardware. You can see from this picture, they put in the hardware so that it's distal to the plateau to try to stabilize as much as they can, but not affect the meniscus, the cartilage, the ligaments. So again, these are just pictures of kind of what that tends to look like. You'll see that the hardware usually goes in on the lateral aspect to help stabilize through the medial aspect. This is that type 5 fracture when we talked about the different ways to classify it. So this is where essentially the whole entire bone collapsed. So with this one, they're having to put in the plates and screws both medial and laterally. So you can see there's a lot of hardware in there to try to keep it stable. And as I said earlier, this is probably going to be a group where they're going to end up with arthritis. Yeah, so let's talk about the complications. So there's a 25% complication rate, which is pretty high. If you think about all the other ones we've talked about, complication rates are definitely more, 10% or less. With this group, we're much more likely to have complications. The biggest complication you're going to see is what's called bone depression. So you can see in this picture, because they don't want to affect the soft tissue, they can't put the hardware, the fixation devices, too far proximally, because they don't want to mess up, again, they don't want to mess up the meniscus and stuff. So when they put those screws in, the area just above that bone could be unstable. That bone could be very weak. And so you end up with the bone kind of collapsing. And then, of course, that's going to affect the soft tissue above it. So the meniscus, in this case, above it, possibly even ligaments. So that can be a pretty important complication to be aware of. It's something you can see in x-rays. So if you're concerned about, pain and soft tissue, irritability, then you may want to do an x-ray to see if they had this bone depression. Infection, compartment syndrome. Again, there's a lot of soft tissue damage oftentimes because it's a trauma. And so compartment syndrome could definitely occur. Just knee stiffness, and then issues with healing of the ligaments. So, sometimes they have to go in and do an ACL reconstruction. Sometimes they have to go in and do other things. So, how well is the MCL healing and those kinds of things. And then there's a 23% chance that they are going to need a total knee replacement 2 years, 3 years later. Again, this is a hard surgery. And the possibility of osteoarthritis is pretty high. But I think this is going to be more in those older people. So you might be lucky enough if it's a younger patient that the cartilage is pretty healthy, that they're not ending up with a lot of arthritis issues in the future. So you'll notice as we go through the protocol here that we definitely are pretty conservative with this patient population. There's definitely very much a protected motion phase with these guys, mostly not because of the bone, really, but because of the soft tissue. So going back and remembering when we talked about meniscal repairs, when we talked about ligament reconstructions or repairs, that we have to be a little bit slow to allow that tissue to heal. So during the first phase, we're spending a lot of time working on independent transfers in non-weight bearing. So we're teaching them how to do non-weight bearing gait with a walker for short distances. We also are working on range of motion, but we're going kind of slow. And I'm going to show you guys the timeline for range of motion. The goal is that by 4 weeks, we have just 90 degrees of flexion, okay? 90 degrees at 4 weeks, which, you know, a lot of other types of injuries and surgeries, we're going to move more quickly than that. But with this one, you'll see it's a slower process for sure. So we're helping them understand how important it is to be non-weight bearing. Again, this is very dependent on how much soft tissue was damaged, but it's true for all of these guys at the beginning. What I think is important, and hopefully if we can do a live lab, you guys will be able to see this. The picture showed them like with knee flexion and standing on the uninvolved side, but I think it's important to recognize that they can put their foot flat. If they're doing static standing, it's okay to put the foot flat on the ground for balance, but also to help decrease the possibility of muscle tightness, hamstring especially, help to keep some dorsiflexion in the foot. So they can move around. Obviously, they need to move around non-weight bearing, but when they're standing, they can put that foot flat and just keep it in a non-weight bearing situation. It's also important they recognize that we need full knee extension. So again, they're going to be in flexion if they have to move around, if they have to do some, go into the bathroom, those kinds of things. But when they're non-weight bearing, when they're sitting down, when they're laying down, we need to make sure that they have full knee extension. We do not want them having a pillow under their knee when they're sleeping or when they're laying down. It's going to cause contractures and it's going to cause them to have trouble with knee extension. So our first phase treatment is going to be patellar mobilization, making sure that patella, remember the patella is fine, right? So we want to make sure that patella is moving really, really well to allow us to work on range of motion more easily. You can do passive range of motion and active assistive range of motion, but we want to focus, and we can focus on flexion, but again, we don't really want to go much more past 90 degrees. Quadricep strengthening, my goodness, I feel like I'm a broken record when it comes to this stuff. You've got to make sure that they can turn on their quad and that they can give you a good quad set, so full knee extension. Be able to, I don't know if they'll get a straight leg raise, but at least get that knee extension in a quad set. And you could certainly use NMES. You can use that electric stimulation if you have access to it. You're going to be doing ankle strengthening and hip strengthening in all planes and non-weight bearing. So all your straight leg raise stuff and ankle plantar flexion, dorsiflexion, inversion, eversion. And then core strengthening as well. So all in non-weight bearing. So our goals are our milestones, independent transfers. So again, remember, these are younger people who are going to need to be able to move around in non-weight bearing on that side. So you definitely want to teach them how to do that. They should be able to do that relatively easily. I put as a milestone here, full knee extension with good quadricep contraction. So that would be being able to demonstrate a straight leg raise. They should be able to do that. I think some patients haven't been able to, but I think most of them can. It's definitely easier than somebody after like a patellar tendon repair or knee dislocation or some of the other things we work with. So non-weight bearing, short distances with gait. So again, that first phase is 6 weeks. It's a long time. That's why they have to be able to do good non-weight bearing gait. But you don't want them to doing a lot of it because, again, we kind of mess up our back if we do too much. We mess up our hips. We can do all sorts of weird stuff to our body, to our mechanics. So second phase, week 6 to 12. And our goals is that we're kind of working our way into more and more weight bearing. So we're going to be at partial weight bearing at 6 weeks and full weight bearing at 8 to 12 weeks. And I'll give you the specifics on that in just a second. But by the end of this phase, so by the end of that 12 weeks, we should be able to do a pretty normal gait. So we're going to spend a lot of time as we increase weight bearing to make sure that their gait looks good. Okay. We also should, by the end of 12 weeks, have full knee range of motion. Okay. So again, we're not pushing too hard during the first 6 weeks. We're not pushing past 90 degrees, but during the second 6 weeks, so by 3 months, we should have full knee range of motion into flexion and extension. So here's a good rule of thumb for weight bearing. Again, I know that surgeons are going to be telling you what to do. This has pretty much followed the timeline, though, that we've gotten from surgeons in China. So this one is not more or less aggressive than what the surgeons are asking. So that's good. This is one where the Western research and the Eastern research is kind of following the same recommendations. So 6 weeks, we're getting touchdown weight bearing. And by week 10, we should have full weight bearing. And then you can see everything kind of in between. So our treatment during the second phase is we can do lots of passive range of motion. We can do active range of motion as well, but we're really trying to get that knee flexion as much as we can. We're going to do like heel raises. We're going to start in sitting and then working our way to double leg heel raises and standing, and then single leg heel raises and standing. Bridges, balance, and proprioceptive type of activities. Again, by the end of this phase, you should be able to do single leg stance, core strengthening, bike, pool exercises. As you start to get them into weight bearing, you also want to look at their movement patterns. And so if you're seeing biomechanical problems with, varus issues or valgus issues, then you need to address that by looking at the hip. So all the things we talked about before. Again, the vast majority of these people were probably pretty active before this trauma. And so their movement patterns probably are pretty good. You're just going to be retraining them on how to do their gait correctly. So again, that's our major goal by 3 months after the injury, is that they can normalize their gait. That they can show good knee extension during terminal stance, that they feel comfortable doing full weight bearing on that involved side. And as I said earlier, they should have full range of motion. This one, again, this is a pretty long rehab. So phase 3 is going up to 6 months. So this is 3 to 6 months. This will probably be more outpatient rehab for most of your patients. And so really our goals is that we want to be able to get single leg stance. We can start doing a little bit more activities in single leg stance, and that they're completely comfortable with equal weight bearing and they look normal with their gait, or if you're starting to do a little bit of running, they look like they're weight bearing on that involved side. So in the West, 42% of patients will have hardware removal or implant removal. So that's a lot in the US. We've talked about this and I've alluded to it maybe a couple of times. Most of the time in the US, unless there's significant pain and we know the hardware is causing problems with mobility, they're not going to take out hardware. So surgeons are going to leave the hardware in. But I know in China, you guys take out hardware for almost everybody in every situation. So in that case, the patient should be aware that the surgeons will probably take out the hardware. And they'll usually tell them that. it's not during this phase, so it's not like 3 months after the injury or even 6 months after the injury. But at some point in the future, they may get hardware removal. And so it's just nice to be able to tell somebody that if they're feeling like it's irritable or something wrong, or if you think it is the hardware that's limiting motion or causing pain, you can tell them, yeah, the doctor's likely going to take it out. Treatment during the third phase, we're going to do lots of leg pressing. We're going to start doing more deadlifts and squats and lunges and all of that stuff. We're also going to be progressing balance activities. And at week 16, you can start running in the pool if they have access to the pool. So at 4 months, they can start doing the movement of running. You also, if you have something like an Alter G, which is the treadmill where you unload, or if you have access to, other treadmills where you can put the harness around them and unload them to like 50% of their body weight, you could certainly start practicing running at week 16 with that as well. The idea is we just don't want full body weight. So once they can do that, and they can do that well, I would say you can start like at maybe 5. And again, by 6 months, they could be running. That's okay as long as there isn't significant movement pattern problems or pain. So again, our primary goal here by 6 months is that our gait is completely normal with running and walking, 120 degrees of knee flexion. So that's not like probably the same as what their uninvolved side looks like. But it's still functional, okay? So they could even use a squat toilet at this point with 120 degrees of knee flexion. That's all that I push this, because again, with that knee flexion, you could end up with soft tissue irritability at the tibial plateau. So if you get more and they're pain-free and they're happy and they can do 130 degrees of flexion, great. There's nothing wrong with that. But I would just say that 120 is fine. You don't have to push it past that, especially if there's pain. By week 16, so 4 months, their strength should be 80% of the uninvolved side. I think that's a pretty fair goal, because we could start strengthening again at week 1 or week 2. So hopefully by 16, they're at 80%. So sport-specific training can start at week 24. And a lot of these people are getting back into sports. So it's important that, again, you can do sort of a long-term outpatient type of therapy with this group. I just want to share this study from the Injury Journal. This was in 2018. This is a study of 90 patients who had tibial plateau fracture. 50% were type 2. So kind of what we looked at, if you remember the type 2, that's kind of that lateral injury, more lateral injury with a little bit of kind of bone collapse, but not a lot, and maybe some soft tissue damage. This group did non-weight bearing for 6 weeks. And then, let me say, there were 2 groups. One group did non-weight bearing for 6 weeks, and that group was 60 patients. And the other group did full weight bearing immediately. No brace, no cast. That was 30 patients. What they found was, of all of the patients, after 3 months of doing their regular therapy, so this was like at the end of phase 2 in the case that we looked at, only 1 patient had more significant joint depression in 2 follow-up radiographs. And that was, so 1 patient in that weight bearing as tolerated group had a little bit of that joint depression, but no functional changes. So their function was fine, but when they did an x-ray, they found that there was a little bit of bone collapse in 1 patient in that full weight bearing group. Otherwise, everything else was good. So what this author recommends is weight bearing immediately after the operation, because they found that it might actually help with healing. And again, only 1 of the patients out of 30 had any issues with bone collapse, but their function was still good. So this came out again in 2018, a couple years ago now. But they really found that their range of motion was good. All of them pretty much had 120 degrees of knee flexion at their follow-up, and otherwise, like, everything else was really good. Good function. So if you're starting to see doctors say, oh, they can be full weight bearing, recognize that there is research to say that they could be and that their tissue might be okay. Remember, this was just mostly type 2 injuries. So type 2 doesn't have a huge amount of soft tissue damage. So if they're more complicated fractures, then that idea of weight bearing is probably not necessarily appropriate. But this research showed that it was okay for this group that did it that way. So here's a couple other references here. Again, you will see tibial plateau fractures. So now you have a pretty good idea of how to progress with them, and how we do need to be more conservative with this group.